So I'm Todd Stoltz. I have sort of an odd job. I do business development and international relations for UC Davis Health System. I'm sort of a junior version of David Lindemann because I'm heavily involved in citrus activities from UC Davis Health System perspective. So welcome to the folks that are watching this from Davis, Merced, and Santa Cruz. Don't worry, I will not be here for long. You'll quickly get to Dr. Adams. A quick background on Dr. Adams. He's a physician in pulmonary and critical care medicine up at UC Davis Health System. His research is focused on host pathogen genomics, which is not what he'll be talking about today. The other side of his research is on clinical informatics, and he's got a really, really interesting project going on at the health system right now in that space that he's going to talk about. His background is mostly from academia in Northern California, so he got his foray into Southern California was down at UC Santa Barbara when he got a degree in anthropology. That may be women and beer drinking at Santa Barbara, I'm not sure. But then there's UCSF, so MD from UCSF, also was a Howard Hughes Fellowship in Immunology there. Did some work at Stanford briefly and then realized the University of California is a little better place to come back to. So now he's doing work at the health system as a critical care fellow for a while now, and now he's a full faculty member there. So without further ado, Dr. Adams.
Thanks, Todd. So just to start, just to say thank you so much for Citrus for inviting me to come down today and speak and for their support of this work. And then thanks everybody for spending their lunch here with us and for logging in remotely. So today I'm going to talk to you about a project which is unrelated to genomics and is really a clinical informatics and analytics project focused on acute respiratory failure study and management in the ICU. So no things to disclose here, so moving right along. The roadmap for today, I'm going to spend the first half of the talk kind of initiating you guys into a little bit of the clinical world of the ICU and of critical care informatics. We'll talk about acute respiratory failure as a syndrome. And then I'll introduce you to this concept of off-target mechanical ventilation and its related concepts of patient-ventilator asynchrony and ventilator-induced lung injury. You can see it's medicine with all the acronyms starting. And then take you on a tour from what we affectionately call the geek bench to bedside and back as a play on the bench to bedside and back of typical translational work in medicine. And then I'll illustrate what we're trying to do with this really with a case study, a clinical case study of how we're actually using these informatics tools for the study of these patients and their management, and then talk about some future directions. So I want to let you guys just sit and absorb this picture for a second. So this is a patient's room I was in last Friday. The image is spliced to protect the patient's privacy, identity. But you can see that your average ICU room, at least at a large tertiary quaternary referral center, is not a relaxing place to get a cup of coffee and sit back. So, so this is an incredibly technologically intense environment. If we actually now look at some of the things that we're looking at here, so you can see in the upper left, we have so-called smart pumps, which are programmable and wireless, capable anyways, that are running all the IV fluids in this particular patient. There's no fewer than 9 pumps, 8 of which are actually active all at one time, delivering life-supporting medications. There's this thing on the lower left here called the BIS monitor, which actually is a measurement of level of consciousness. And then there's a whole series of life support devices, including a mechanical ventilator and hemodialysis machine. In the lower right, you can see this thing that we call the ECLS system, or extracorporeal life support. This is actually taking all the blood out of the patient and the cannulas that you can see running to and from the patient's chest, and actually taking it and running it through a small artificial lung. It's about the size of half a box of Kleenex. It has a surface area of a tennis court. In order to actually provide oxygen and carbon dioxide removal, and then runs it all back into the patient. And then there's a whole series of monitors. Every one of these devices is full of streaming data. So typically waveform data, high sampling rate, 50 to 200 hertz. We use these data for clinical decision making at the bedside. And we take multiple streams of these data, and we use gray matter processing at the bedside, usually after about a decade of learning how to do it, to actually integrate those streams of data and translate them into actionable information that results in a diagnosis, a plan of care, and an anticipation of untoward events. So we in the sort of informatics space of critical care we sort of jokingly referred to the ICU as healthcare's large hadron collider. And if you look at the amazing stream of data that are coming from all these things, there's no other place in healthcare that's this data rich, but at least on the secondary use and analytic end, this data poor. So what we've done in my lab is really focus in on mechanical ventilation and acute respiratory failure as a use case, both for its intrinsic merit as far as the burden of disease and what patients need, but also as a generalizable use case to generate architecture and solutions within healthcare that can be then extended into other areas beyond respiratory failure, both in critical care and elsewhere. So just some premises about critical care. Many people have never been to an ICU and don't know much about what happens there, but you know, the places where we provide critical care include the emergency department, to an extent the operating room, and the intensive care unit. And these are really the most data-rich and medically, physically, meaning that the geography and technologically complex areas in the entire hospital. Timely diagnosis and management is absolutely key in critical care. Things in the critical care world evolve second to second, minute to minute, hour to hour. Those are our time frames. And this really requires access to and integration of multiple data types. And then basically, as I said before, the translation of those data streams into actionable information. You would think in the modern era, what people call the era of the electronic health record, that this would be our one-stop shop for informatics solutions for patient management, and it's not. So you may or may not know that most electronic health record systems, their primary service to healthcare is really to archive relatively static information and to bill, to provide a bill. Not to use data for secondary use. So they're really not designed to store or to access very high-frequency data streams. So sparse data, okay. Rich data streams, not so good. And then the other aspect of them is that even though they require a tremendous amount of horsepower to run, to operate, there's not much horsepower that's actually dedicated to processing clinical data. So as a compute environment, your electronic health record is very, very rudimentary. So the result at the end of the day is, despite this amazing wealth of data sitting in electronic form now, much of it is still inaccessible. And this results in limited understanding of many very, very common critical illnesses, limited understanding of how we interact with patients as far as the healthcare patient interactions and their impact on clinical trajectories and outcomes, and very limited availability of any clinical decision support tools that rely on data analytics. So with that in mind, the project aims that we focused on were to develop a mechanical ventilation-focused cyber-physical system that would support ventilator data acquisition as well as analytics development, that would allow us to study the relationship between off-target mechanical ventilation and patient outcomes, something for which very little is known, and to support the development of a parallel computing environment, a cloud-based decision support platform that would then allow us to improve the management of patients, circumventing the limitations of the electronic health record. And more broadly, as I said before, we really wanted this to serve as a leverageable use case. So we call this our Bedside to Cloud, or B2C project, as a use case for the broader development of tools within critical care that would allow us to do a better job of clinical state classification, so developing ways of actually identifying clinical states or phenotypes, to develop predictive analytics systems that would allow us to then anticipate untoward events and clinical outcomes, and then more broadly support cloud-based efforts to generate computing environments for both research and decision support outside of respiratory failure specifically. All right, so a little bit of background on the intensive care unit. So we call this not only the intensive care unit, but the expensive care unit. So $121 billion per year in attributable costs. That's as of 2008. And this has only increased, but there are no more recent data available. A little bit more recent, as of 2011, about 1 in 4 adult ICU admissions to the hospital include an ICU stay. And if you look in the column here, if your hospitalization includes an ICU stay, the costs associated with that are 2.5 times the cost associated with admissions that don't involve a trip to the ICU. This is somewhere in the neighborhood of 15% of all U.S. hospital spending, about 5% of total U.S. healthcare spending. That means all healthcare spending just on the intensive care unit. And these are very old data, but as of the early 2000s, this was actually a measurable fraction of the entire U.S. GDP just on the ICU alone. If you end up requiring mechanical ventilation, you're talking about somewhere in the neighborhood of $1,000 a day in increased costs just associated with the use of mechanical ventilation. So this is, in fact, expensive care. So with regard to acute respiratory failure specifically, so this is from a large national inpatient survey run by the Agency for Healthcare Research and Quality. This survey is actually 47 states and about 350 million inpatient admissions. And as of 2009, there were about 2 million admissions per year that involved acute respiratory failure in the US. Most common causes of respiratory failure, as far as what was coded, are things that are all familiar to most people. So pneumonia, congestive heart failure, chronic obstructive pulmonary disease, sepsis, and ARDS, which is called the acute respiratory distress syndrome, which is a very severe subtype of acute respiratory failure. About half of all those cases require mechanical ventilation. And as far as attributable cost to respiratory failure, a very sizable fraction of the total ICU expenditures, so $54 billion a year in hospital costs associated with admissions involving acute respiratory failure. So about 800,000 admissions per year involve mechanical ventilation specifically in the United States. And just for reference, the population incidence, if you're used to thinking about things in those terms, is 270 per 100,000. That's actually more than the sum total of breast, prostate, and colorectal cancer combined. So this is a very common problem. And if you compare it to another acute medical illness, namely acute myocardial infarction or a heart attack, it actually beats that still by a decent stretch. Now, if you look at in-hospital mortality of acute respiratory failure, this is the real deal. So 1 in 5 patients that are admitted with acute respiratory failure will not leave the hospital alive. And if you require mechanical ventilation, meaning if your respiratory failure is severe enough that you require a breathing tube and a machine to help you out, 1 in 3 of those patients will die in the hospital. And if you compare that to a heart attack, which is something that gets everybody pretty worked up when a patient rolls into the emergency room with an acute MI, in-hospital mortality as of 2013, the most recent data, 5.5%. The last time that acute MI mortality was in the range of that for acute respiratory failure was in the 60s. But through very intensive research and focus on improved clinical management, that mortality has been reduced by many-fold. And clearly, respiratory failure is behind the times in the attention that's been paid to reducing adverse outcomes. So it turns out that if you live, it's not all gravy. We used to think, okay, you just have to get people over the hump, and once you get them out of the ICU, it's all just, downhill from there, easy going for the patient. But a fair amount of work over the past decade has actually revealed very high rates of cognitive dysfunction, post-traumatic stress disorder, and long-term disability in survivors. This is very well illustrated by a study that was published in 2013 called the Brain ICU Study, where they looked at over 800 patients that were admitted to the ICU with either respiratory failure or cardiogenic or septic shock. You can see pretty comparable to the overall statistics nationally for respiratory failure, mortality was very, very high. So 1 in 3 gone by 90 days and almost 40% by 12 months. If you look at all the cohort combined, 2 or 3/4 of those patients suffered from delirium. So that's where patients become very disoriented, hallucinate, severe cognitive dysfunction with delirium at some point in their hospital stay. And if you look at people who survived as of 12 months, 1 in 3 of those patients had cognitive impairment similar to patients that have a moderate traumatic brain injury. 1 in 4 of those patients have cognitive impairment that's similar to patients with Alzheimer's dementia. I think if you really want to illustrate what this is like for patients, you have to hear it from the patients themselves. So Nancy Andrews is a patient who's very well known. She gives a very chilling TEDx talk on having survived critical illness. And so I'm going to read you a couple quotes, 1 from her and 2 from patients from our own intensive care unit, which is part of the work of one of my colleagues in nursing, Amy DeRoy, who's actually been interviewing patients who are ICU survivors to figure out what aspects of their experience might be improved upon. So Nancy says, in reality, the ICU is a torture chamber. If you take away the knowledge that everyone is trying to keep you alive, what is actually happening can be pretty dreadful. Being on a ventilator is a nightmare, and your ability to communicate by speaking is taken away. Patient 5 from our own ICU at UC Davis says, I remember vividly waking up one morning, having a panic attack, and the machine wouldn't allow me to speak, so I was yelling or trying to yell for someone. Yelling, and the machine was forcing air into my lungs, and I was trying to yell. I felt like I was suffocating. Having put myself on the ventilator many times for my research, I can tell you it is not a comfortable experience. And the final quote, which always makes me feel like I'm a terrible person for practicing critical care medicine. The patient says, I hated that tube. I thought I was dying. But when they took the tube out, I finally felt like I could breathe. Seems a little opposite of the way it should feel, but nonetheless, the point I think is well taken that this is not something easy for patients to tolerate, and we have much room to move on making patient experience better. All right, so after the big downer of critical care medicine, everyone just relocate your happy place and recap kind of where we've been here. So ICU, hopefully, you've gotten the sense this is a fairly chaotic location to take care of patients and to be a patient. It's very data rich but information poor. And it's very high stakes for the patients, but potentially very high rewards because we have a tremendous opportunity to impact patients' lives in positive ways. As far as reasons for critical care informatics development, we have very limited access to much of the data that we use for clinical decision-making at the bedside. You now know that EHRs, electronic health records, are not built for the type of high-volume, high-speed data that are common to medicine nowadays or for data integration. And there's very little computing resources that come along with them. And actually, there's no way at present to actually take the actionable information that we derive from these data streams and push them back to providers in real time. So an electronic health record, you actually have to log in. You have to pull. There's no way to push to the provider, and certainly no way to do that on a rolling basis. And finally, with acute respiratory failure and mechanical ventilation, again, very high-risk condition, high cost, both in terms of lives and suffering, as well as in actual dollars, and very, very unpleasant for patients. We need better tools for management and for the study to improve the science. And I hope you now are starting to get the sense that this is an excellent use case to develop more generalizable critical care informatics architecture. All right, so now it's time for the deep dive. Everything you ever wanted to know about mechanical ventilation, but were afraid to ask. So this is the basic setup. So when patients develop respiratory failure, in order to actually provide support from a breathing machine, we actually need to have a closed circuit. This is positive pressure ventilation, no longer the iron lungs of the olden days. And what this actually involves is the placement of something we call an endotracheal tube. So you can see on the right-hand side of the screen, this tube is actually inserted. We actually have a special scope that we actually place this down into the back of the throat and then into the windpipe. And we pass the tube down into the trachea. And when it gets down to the point where it's hovering above the branch point between the right and left lungs, we inflate a balloon. And what that balloon does is it seals the thoracic cavity. So it creates a closed space so that air cannot escape out around the tube, but only has one conduit in and one conduit out. That's connected to a ventilator circuit that has both inspiratory and expiratory limbs, and those limbs are then connected to the ventilator, which uses pressurized gas from the wall, oxygen and air, and then uses inspiratory and expiratory flow sensors in each of the limbs of the circuit to then regulate flow, both pushing pressurized gas in so that air then flows down that pressure gradient into the patient, insufflating the lungs, and then opens up an exhalatory valve and lets that air come rushing back out, most of the time passively as the chest wall recoils and forces the air back out, but also actively if the patient is forcibly exhaling. And this is it. Air goes in, air goes out. That's all you need to know. So as far as the way that the breath looks, well, I got audio. I don't know if you can hear the audio. So in any case, we actually use waveforms to do a lot of the clinical management, both to diagnose problems on the mechanical ventilator as well as to fine-tune the way that the patient and the ventilator are interacting to support them through their critical illness. So you can see down in the lower left, the breath starts, and what you see is a rapid rise in inspiratory pressure as the ventilator provides work and assistance to the patient, and flow rapidly spikes up as inspiratory flow begins. And then as the chest wall forces begin to oppose that inspiratory pressure, flow tends to slow down. And at some point, usually pre-specified by the ventilator, the assist turns off and the expiratory valve opens up, allowing exhalation to begin, which you can see down in the lower figure as the area of the curve below the zero line. And then at some point, one exhalation ends, the breath ends, and the process begins anew. So we can actually derive a tremendous amount of information from this, as I said. So we can have discrete data fields like the peak inspiratory pressure that gives us a sense for how much maximum push is going into the patient. We actually regulate the pressure on the way out to keep lung units from collapsing at the end of exhalation. We call that positive end expiratory pressure. And then we can look at the difference between those as the driving force that's providing help to the patient. We can then take the flow time curve and do simple things like integrate the area under that curve. Because this is a liter per minute at each instantaneous time point, the integral of that ends up yielding the inspiratory tidal volume. and then we can do the same the area under the curve. This is what the ventilator does and shows us these parameters on the user interface of the ventilator. So this isn't a normal situation. So now we have this concept of off-target mechanical ventilation. And this is when things are not going well. So there's two main categories of off-target mechanical ventilation. One is what we call tidal volume violations. And that's the delivery of inspiratory tidal volumes that are large enough to actually hurt the lung. It can actually injure lung tissue, and I'll explain that a little bit more shortly. The other is what we call patient-ventilator asynchrony, sometimes in the literature also seen as dyssynchrony. And this is when the patient support from the ventilator is less than what the patient is asking for. And this results in this sense of distress on the part of the patient, and the patient starts to fight or buck the ventilator. And this, when you see it in front of you, is really quite dramatic. And you watch families sit at the bedside and watch their loved one as they're bucking the ventilator. And it's a fairly violent scene, something which is quite striking. This is a major source of patient discomfort in the ICU. And both of these phenomena can result in what's called ventilator-induced lung injury. And this is, again, a situation in which ventilator support is delivered in a way that directly injures the lung and can actually, by itself, create all the features, clinical features of acute respiratory failure that might be occurring from a normal disease process like an infection or a trauma. So the way that this works, there are three major mechanisms of ventilator-induced lung injury. So one is called volume trauma, and this is, again, when volumes are delivered that result in sort of maximal distension of the air sacs of the lung, which we call alveoli. And you can see in the case of normal versus the hyperinflated picture where everything is maximally stretched. And this results in biological injury to the cells that line the lungs, as well as the capillaries that bring blood to and from those air sacs. Atelect trauma in the middle panel occurs from repetitive opening and closing of those air sacs. So you can see that at the end of exhalation, if you don't manage the ventilator correctly, a lot of the lung collapses down. And then the next breath in, it pops that lung back open. And those shear stresses result in biological injury to the lung as well. And then the final type of ventilator-induced lung injury we call barotrauma. And this is where excessive pressures actually result in physical disruption, a break or a tear in either the air sac or the breathing tubes. And this results in collapse of the lung. And while the last one, barotrauma, is quite dramatic because it can result in cardiac arrest if it occurs very rapidly, it's actually the least important of all the forms of ventilator-induced lung injury. And it's actually this volume trauma and atelect trauma which results in severe biological injury to the air sacs of the lung, which causes cell death of both the lining cells as well as the blood vessels that feed them, and actually results in collapse of lung, alveolar flooding, and severe hypoxemic respiratory failure. And it turns out that if you do this in experimental animals, just by mismanaging the ventilator in the animals, you can recreate all the features of severe acute respiratory failure, both at the clinical level and microscopically, just by managing the ventilator inappropriately. So with regard to patient-ventilator asynchrony, again, these are stereotyped waveforms. So we actually spend a tremendous amount of time in critical care medicine learning how to make these diagnoses to capture when these things are happening so we can fix the problems. And this takes years to get good at. But it turns out that the waveforms are fairly stereotyped. So as two examples that you'll see in a second on the right, we call something a double trigger asynchrony and flow asynchrony as two illustrative subtypes. So with double trigger, it's pretty self-explanatory. You can see there's a double hump. And so what ends up happening here is that the vent has a programmed inspiratory time that we call the I time. If the patient has a neural inspiratory time, a desired inspiratory time, which exceeds what the ventilator is providing, the ventilator cuts them off early and they continue to suck in, triggering the next breath. And so instead of getting the volume of breath that you intend, they get a double breath, potentially resulting in volume trauma and ventilator-induced lung injury. It's also very unsettling for the patient. Flow asynchrony, which is something I've done a lot of simulation work on and is frankly really miserable, occurs when the patient's flow demand is greater than the vent's flow supply. So in one of the most common modes of mechanical ventilation that we use, something called volume control, the ventilator actually has a programmed slope of flow delivery. So the morphology of that inspiratory flow curve is actually completely set by software, and it's inflexible. So if a patient wants significantly more flow than is set by the ventilator, the patient doesn't get it. And what ends up happening under those circumstances is the patient starts to expand their thoracic cage around a relatively fixed volume of gas, dropping the pressure in the circuit. And so even though gas is coming in, it's coming in at such a slow rate that the patient feels like they're trying to inhale forcibly through a tiny little drinking straw. And so you can imagine what that feels like when you're in distress. So what does this actually look like as far as the science is concerned? So it turned out that back in the 70s, experiments that were done using very high pressure, the kind of pressure that was being used for patients at the time, showed that you could really wreck the lung. And people started to wonder, well, is this really the pressure or is it the volume that occurs when you distend the lung with high pressures? And so some very neat experiments that were done in France actually in the late 80s. And suffice it to say, they did a series of experiments where they ventilated experimental animals with high pressures and high volumes, or low pressures and high volumes in little tiny rat iron lungs, if you can believe it. Something we might be able to make downstairs. And basically showed that you could destroy the lung by many different measures of characterizing the lung damage. But if you ventilated the patient with the same high pressures but low volumes, the lung was completely protected. So this was actually done in experimental animals all the way from mice to sheep and was very, very reproducible across species. And it turns out that when they started to do these experiments in people, it's not very good for people either. So this is a classic trial, probably the most well-known trial in all of critical care medicine, published in the New England Journal of Medicine in 2000, called the ARMA trial. And they basically said, based on all this data and some small pilot clinical data, what happens if we actually randomize patients that have lung injury from a disease process like a pneumonia, for example, to receive very restricted tidal volume, so on the order of breathing in and out the volume of a Coke can, compared to double that tidal volume, which was very common at the time. And they showed on the left that mortality was 31% in the group receiving the restricted tidal volumes and almost 40% in the group receiving the higher tidal volumes that were common practice at the time. So a 9% absolute risk reduction in mortality is about as good as anything in all of healthcare. So we call that a number needed to treat of 11 patients in order to save a life. There's very few things that we do in all of medicine that are that effective. So as far as patient ventilator asynchrony is concerned, much less is known about this. There's some small trials that suggest that it's associated with adverse clinical outcomes. And probably the best data, or at least the most provocative data, comes from a trial that was published in 2010, also in the New England Journal, called the Acute trial. It was a multi-center French trial in which they took 340 patients that had early onset of acute respiratory distress syndrome. So they caught them very early in their clinical course when the clinical course may still be modifiable. And they were randomized to 48 hours of chemically induced paralysis, meaning taking a drug that completely paralyzes every muscle in the patient's body versus just having them sedated on the ventilator alone. And this trial, similar to the initial ARMA trial, showed lower 90-day mortality. Again, almost identical result, but this is additive because these patients were otherwise managed with low tidal volume ventilation. Also showed less of that rupturing of the lung, less organ failures, and shorter times on mechanical ventilation in the ICU. The interesting thing about that trial was that there was no difference in the recorded ventilator settings. So the volumes that were used, the pressures that were used, the amount of supplemental oxygen was actually identical in the paralyzed arm and in the placebo arm. And people have hypothesized that it's the elimination of all that bucking and fighting of the ventilator and these really unmeasured waveform-based adverse patient-ventilator interactions that may have explained the improved outcomes in the paralytic arm. All right, so with all that in mind, we sought to develop some new health informatics solutions that would help us to be able to get at what's happening with patients and turn that around into improved science and improved management. So it turns out, though, as you've probably guessed from what I've told you so far, that there are a lot of challenges to doing this in a healthcare environment. So one is data access. So many of these devices never make it into the electronic health record, especially things that use high sampling rate waveform data. And those that do typically just snapshot those data maybe once an hour or at most once every few minutes for bursts. And device interfaces, as you can also imagine, tend to be proprietary and very expensive. So to try to hook a ventilator into the electronic health record just to get snapshots is thousands of dollars per ventilator. Data transmission turns out to be a problem in the health system. So clinical wireless networks have really not been built for high volume data transfer. So you end up with bandwidth issues and reliability issues that can create problems when you're trying to use these systems clinically. Data storage is an issue. So the databases, as I've talked about previously, are really not designed for this type of work. And looking at something like mechanical ventilation data that we work with, 4.3 million rows per day per patient, 150 megabytes is not that big of a deal in the grand scheme of data storage. But in a healthcare environment, it's a huge deal. And as far as analysis is concerned, there are really no good off-the-shelf software solutions for looking at streaming patient data. And within the EHR, if you try to develop this and deploy it within that self-contained environment, there's really no R&D sandbox, and there's no simulation environment to do iterative work and preclinical testing. And then finally, the visualization arm of this is also a problem where there's really no visualization packages that are readily available, and certainly not open source, that can handle these large volumes of clinical data streams. So just as a quick reference, there's these challenges, people talk about with big data are really all relative. And in healthcare, we're really on the very sort of small end of big data compared to most other things. So if we're talking about, the uber big data reference, if you look at CERN's Large Hadron Collider, we're talking about a petabyte of data per day. One ventilator, 150 megs a day, 55 gigs a year, absolutely dwarfed by many other applications. And if you hooked up every single mechanical ventilator at UC Davis Medical Center and collected data every day of the year, you'd be talking about 2.5 terabytes per year. So still very, very small requirements. But if you look at the entire subset of data, if you exclude imaging data, but just look at every other piece of data in the electronic health record, it's only about 11.5 terabytes. So just hooking up ventilators alone would occupy a substantial fraction of all the storage requirements that we currently use for non-imaging data. And if you look at non-imaging data requirements for your average electronic health record, these data come out of the the Beth Israel in Boston, only about 80 megs per patient per year. So 10 pages of single-spaced Microsoft Word document. So we're not talking about huge data in healthcare yet. The velocity piece is also interesting, right? So the LHC is 10 gigs per second maximum capacity to handle data coming out of their experiments. With a mechanical ventilator, which is actually a very high-speed stream for healthcare, it's 2 kb per second. So not exactly an unsurmountable obstacle. The variety piece in healthcare, we actually have a fair amount here. So in healthcare, we talk about the integration of many different data types. So formally structured things like labs, semi-structured things where healthcare providers are actually entering data into flow sheets that then have some structure to them. And then fully unstructured things like waveforms, images, clinical documentation, and all these need to be integrated in order to distill information that can be used for science or for clinical management. And then the final piece, which is quite different, right, is the veracity of the data. So quality control becomes a big deal in clinical medicine because garbage in, garbage out doesn't just result in bad experimental data. It can result in harm to patients. So we have a fair amount of work to do there. All right, so our system, we call the Bedside to Cloud or B2C system, really has several different components to it. So you can see on the left, we actually start with where the data are generated. So we do a lot of simulation work in the Center for Virtual Care, which is an embedded simulated hospital within our Center for Health and Technology at UC Davis. And then now we're actually within the emergency departments and ICUs collecting data directly from patients. We use a ventilator here that you see called a Puritan Bennett 840, which we serve, suffices as as sort of a general patient monitoring device. And then what we've done for our very high-tech solution to device interface and data acquisition is use Raspberry Pi, little small open-source microcomputers. And we've developed custom software to deal with the device interface driver problems, as well as to interact with the UC Davis Enterprise Wireless Network for data transmission. And these data get backed up once an hour onto a centralized network project server. From there, we've actually been building an AWS-hosted secure computing environment. We're currently in the process of getting this vetted with our local IT security to have full HIPAA compliance so that we can store protected health information in that space. And so we basically have been building a compute environment to run Python, which is where our decision engines, how our decision engines are coded, as well as R for statistical analysis, and then a research database, which can then accept feeds from outside sources. So right now, this can be accessed through web interface. When it becomes HIPAA compliant, this will be done actually through either the UC Davis intranet or VPN access to really tightly restrict who has access to a space that contains private health information. And we're now starting to build the pipes to take data directly from the electronic health record and our critical care registry locally to provide the clinical metadata to build out the context for interpreting the mechanical waveform data. Eventually, what we're starting to build out, but still in very, very fledgling stages, is the ability to then push these data to critical care providers at the point of care for use in clinical decision support, and actually to take analytic output and feed it back into clinical systems so that some of that information can be used for clinical documentation and slightly less than real-time clinical decision making. All right, so what does this whole preclinical simulation environment look like? So here is a simulated ICU room within our Center for Virtual Care. That's JP Del Plonk, one of our engineering faculty co-investigators on the project, and one of our programmable mannequins that you can actually intubate and that can sit there and breathe on the mechanical ventilator. We've done a tremendous amount of device interface and hardware as well as software development, working out the details of taking this open source small computing device and adapting it to be a data acquisition device for a clinical mechanical ventilator. That thing on the upper left here is actually simple things that are all familiar to you guys, like 3D printing custom-made device to basically hold the thing so that it doesn't keep falling off the back of the ventilator, which is what it was currently doing when we first started the project. And then we've used this also as a place to, again, before we ever get close to a clinical environment, to do a lot of the development work for interfacing our devices with the enterprise network and then NTP time server to ensure that all the data streams are time synchronized. And then finally, we've used this environment to generate very large simulated data sets for use in algorithm development and validation, as well as to do actual device deployment and clinical workflow simulations. It's one thing to have this all dialed in and figured out, it all works, but then you actually go to implement this in a clinical environment that's bustling, that's complicated, that has a lot of other equipment in the space, and you suddenly realize things need to be done differently. And so we were able to do all this work and really have the whole system very, very streamlined, requiring very little modification by the time we deployed it in clinical environments in the ICU, in the emergency department. So as far as quantification of the data that we get, so we've tried to say, okay, well, can we actually do this in a very granular way, much more granular than has ever been possible? And so we've developed algorithms that can essentially slice and dice the tidal volume data into tidal volume violation ranges, so that on target up top would be akin to the standard of care for patients that have respiratory failure. The severe tidal volume violation at the very bottom is akin to the control group in that original ARDS-net trial that showed significantly higher mortality, and then we can grade these in between any way we want. These are the categories that we've chosen. And then we have a number of common patient ventilator asynchrony waveforms that we've developed sub-algorithms for, as well as common clinical artifacts. So here's that double trigger. This is actual patient data here. Breath stacking, which is a less severe form of that, in which the patient has an incomplete exhalation before being stressed and taking the next breath in, trapping gas and potentially over-distending the lung. That flow asynchrony. And then a series of common clinical artifacts, like the patient coming off the ventilator, coughing, or being suctioned, that can result in false positive classification of actual patient ventilator asynchrony. So we've developed algorithms that can help to improve the specificity of our classification. So as far as how we do this process, as far as algorithm development and validation is concerned, so we basically developed the core algorithm logic using simulated data. Most of it comes from what we call Adam's lung, and then we have a test lung up top that you can see as well. And then we work on algorithm refinement and exception handling using patient-derived data. As you can envision, patient-derived data is incredibly messy compared to the clean data that come from even me struggling on the ventilator. As far as algorithm validation is concerned, we use a gold standard approach. So we actually take the clinical waveforms as well as the simulated data sets. Myself and one other pulmonary critical care physician hand annotate every single breath in our data sets independently. We come back and resolve disagreements by consensus and achieve a gold standard. We've now painfully annotated thousands of these breaths so that there's really a clinical expert classification. And then we do derivation validation experiments to determine final algorithm performance relative to the gold standard. We do both equivalence and non-inferiority testing to ensure that the algorithms are performing well. So this workflow basically goes from the ventilator itself, which actually outputs an ASCII data stream through one of its serial ports. We connect the Raspberry Pi, which is the more recent ones that we're using are the Pi 2 Model Bs, pretty sophisticated and way overdone for what we need. And this outputs CSV files that are recorded onto the Pi and then sent to the central server once an hour. The CSV file basically has, in a raw form, just 2 columns of data. That's it. So you can see on the left of those 2 columns is flow, and on the right is pressure. And then we actually add date time stamping at 50 hertz for use in processing from an algorithm logic standpoint. And then we generate a Python rules engine. We have breath type specific algorithms in which we translate the clinical rules that I would use at the bedside, which are very logical, into a series of logical operators within Python, and then ultimately integrate the sub-algorithms into one large rules engine. From that, we get a tremendous amount of output. So we actually pipe the data into a visualization package that's built on digraphs to help us to then look at the waveforms, one of the few packages that, at least that's open source, that can handle the enormous amount of data points that we're drawing. And then we have a series of matrices that produce output. So one we call the breath metadata output. This actually, you can see breath number in the rows, and then things like the inspiratory and expiratory tidal volume, peak flow, peak pressures, and PEEP. All of these we can actually reverse compute from the raw waveform data themselves. And then finally, we have a breath type classification output. And in this case, again, breath number on the x-axis of this table, and then each of the different subtypes, either a tidal volume violation or different subtypes of patient-ventilator asynchrony or common clinical artifact. And we can classify these breath by breath throughout all, let's say, 40 to 50,000 breaths that the patient may be taking per day. So how we do this from an algorithm perspective is pretty straightforward. So we basically take the clinical rules and break them down into very discrete units of pseudocode. In the case of, for example, deriving the inspiratory tidal volume, it's very straightforward. We integrate the area under the curve using Simpson's method, starting from the start of the breath to the point at which the flow crosses the 0 mark and goes from positive to negative. We call that x0, or the cross 0 point. And from that, we can then get the integral, which gives us a tidal volume. And then we can use that to have a classification event and saying, hey, for this patient at that volume, this is an on-target breath. It turns out this is pretty easy once you have the x0 point dialed in. It turns out that in the messy clinical world, that the waveform oftentimes has so much artifact around crossing 0, we had to generate a tremendous amount of algorithm logic and exception handling to the point where we could get this to be highly accurate. We can just simply invert that same process from the x0 point to breath end and get the expiratory tidal volume, and then use those two features to then do classification of patient-ventilator asynchrony. So if we look at something like the double trigger algorithm, we have a series of just if-then statements. So if the tidal volume expiratory to inspiratory ratio is small, as you can see with the first blue peak and the green peak, the tiny little green peak below, and the time in between breaths is very, very short, then we assign a class of double trigger, pretty easy to follow. We can then actually have a little bit more complex logic and say, all right, well, if the class is double trigger, then we can actually sum the two inspiratory tidal volumes that are part of that clinical event, subtract the small amount of volume that was exhaled, and then actually merge those into one breath event, because that's what the patient's lung sees, to get a final tidal volume, in this case 690 milliliters, and then assign a subsequent class of tidal volume violation to that, which would then become a moderate tidal volume violation. And then we can use that across different algorithms, modifying it as needed in order to do all the subsetting into individual PVA subtypes. So how we've done as far as validation is concerned, so our tidal volume validation is incredibly tight. So these were experiments that were done in which we basically just dialed the tidal volume into the ventilator and then looked at what our algorithm was computing for the calculated tidal volumes, and we're off by just a few percent. We have a pre-specified equivalence threshold of about 10% here because the ventilator manufacturers themselves quote a breath-to-breath variability in their own ability to be accurate of about 10%. We're well within that tiny little error bars because there's so little variance in the data. If we look at the exhalatory side, same thing. Now we can actually compare to what the ventilators chart for their own exhalatory tidal volumes. We undershoot consistently by a few percent. They overshoot, but very, very tight. If we look at how we're doing with our double trigger asynchrony detection, so in this case, in a derivation validation cohort in our validation data set, our clinical reviewers are almost perfect. The algorithm does a pretty good job as far as overall accuracy is concerned. We do a very good job of detecting all these. We're getting increasingly good at refining and subtracting out some of these clinical artifacts to improve our specificity, and that's where the remaining algorithm validation work is currently occurring. So I'm going to now illustrate this and sort of tie it all together for you with a clinical case study, which hopefully you will see the potential of this approach. So this is one of our first patients, patient number 8 that was enrolled in our study. She was a 66-year-old woman who was admitted to the emergency department and then to our medical intensive care unit. She had septic shock and this very severe acute respiratory distress syndrome from a bilateral multilobar staph pneumonia following influenza A infection. So this is a common situation of superinfection, bacterial pneumonia following flu. So she was intubated emergently in the emergency department and then transferred up to the medical ICU about 3 hours later. Within an hour, we got one of our Raspberry Pis on, enrolled her in the study, and began data collection. I was actually up there in the early phase of the study doing research-related stuff and was pulled into her clinical care. So it was kind of neat. I got to see her clinical course unfold and then see what the data showed afterwards. About 10 hours into her care, we actually paralyzed her. So she was completely out of control. It was really a rapidly sinking ship. And even though we don't like to paralyze people, because you can imagine this is not good for you in many regards, it can be life-saving. And so this was started about 10 hours into mechanical ventilation for worsening hypoxemia, out-of-control tidal volumes, and very, very severe patient-ventilator asynchrony. This is a plot of our current state-of-the-art if you look at the electronic health record. So the way that volumes get recorded in the electronic health record now is that a respiratory therapist walks up to the ventilator, they stare at the screen, they take a piece of paper and a pen out of their pocket, and they write down the volume, and eventually they make it back to the electronic health record and they type it into a flow sheet. So in the 4 hours prior to the start of paralysis, when she was completely out of control at the bedside, these are the tidal volumes that were charted for her on the x-axis. The red bar is the standard of care, what would be considered perfect management of this patient. The yellow bar up above would be considered not quite standard of care, but not out of control. It would be considered to be marginally acceptable. Anything above that, totally unacceptable. No one would ever look at volumes up there and say, you're doing your job. So as you can see here, she had basically a sum total of 5 breaths recorded in those 4 hours, only one of which was over the threshold of completely unacceptable, a few of which were in that sort of gray zone, and none really were within the standard of care. If you look at what was actually happening in her at the time, this is what our platform is able to deliver. So this is where we are now as far as being able to generate data with this degree of quantitative specificity and granularity. And you can see here tremendous lack of control in this patient. I mean, this is why we paralyzed her. This is why I spent 3 hours at her bedside trying to get all this dialed in that evening. And a completely different picture of what's happening to the patient. You can also see differences in trend, even at this 10,000-foot view, of what's happening over different phases of the patient's care, things that really don't come through in a standard electronic health record capture of patient data in patients who are critically ill and evolve in this minute-to-minute, hour-to-hour trajectory. So what we can now do with this is really drill down into the data. So this is a way that we can now say, well, now we can divide phases of care into clinically relevant phases and start to look in a much more granular and quantitative way at what's happening. You can see double triggers, severe breath stacking, and moderate breath stacking in the 3 colors respectively. If you look at the first 3 days, which would be a common interval in which somebody would sum up what's happening to the patient, in that red circle down below, it looks pretty unimpressive, 1% as a maximum rate. If you drill down into clinically relevant phases of care, though, you can see dramatically different pictures. So in that pre-paralysis phase, you can see that the patient was pretty out of control, and as soon as she was paralyzed, everything gets dialed in, and even after the release of paralysis, things stayed dialed in. So a very, very different way of looking at the patient. And if we want to then even go within phases of care, things that we've really not been able to do up to this time, we can drill all the way down into hourly quantitation, even minute-to-minute quantitation of what's happening to the patient, and look at how completely out of control the patient was relative to what you would see from the electronic health record, as well as how that changes over time, trending. And you can see actually what basically happened to this patient, because I was there, was that when she first came up from the emergency department where she was heavily sedated, her sedation was lightened to do a neurologic assessment. She completely fell out of control. And then you can see that the bars start to trend down on the second half when we're increasing sedation, but we're still unable to get her, despite being in a deep coma at that point, under control again, at which point paralysis was started. So this degree of granularity is what's made possible by having a direct view of the bedside through analytics. So our recent progress, this table is a little bit out of date, but the title is not. So we actually, just as of yesterday, enrolled our 140th patient in the study. We have 34 patients that have this very severe form of respiratory failure where the stakes are highest. This table was actually put together when we only had 18 of those patients who had data extracted. About 2/3 of these patients had very severe ARDS. We're actually doing pretty well as far as our hospital mortality of only 22%, only 1 in 5. which is still very striking. If we look at where we're going now, so the last of the work that we're doing right now is validating the performance of our fully integrated decision engine. And that's really now incorporating in these mechanisms to filter out the patient artifacts. We're now starting to look at the epidemiology of off-target mechanical ventilation in the ICU. This is something which is not well understood. The largest study that's been done to date had 50 patients. So we're almost at triple the sample size of the largest publication to date in this space, and we have many more data points than what's been done previously, because people have done very short sampling, 5 minutes, 30 minutes of data to represent an entire day's worth of patient management. And then we're starting through a second Citrus grant to work on the development of machine learning classifiers as well as predictive modeling using machine learning to anticipate those patients that will develop ventilator-induced lung injury before it happens, rather than waiting for it to happen and trying to fix it once it's broken, as well as looking at other clinical outcomes like mortality and time on mechanical ventilation. We're starting to actually get now into some pretty interesting territory as well. Because we can actually access data the second the patient starts on a mechanical ventilator, we can start to look at off-target ventilation very early in the course of respiratory failure. And the key here is that this is the point at which things may be modifiable. The horse is not out of the barn yet. And if we can actually manage the patient very, very tightly, we may be able to send them down a very different clinical road. This has been done in sepsis management. This has been done in acute myocardial infarction and has yielded tremendous fruits in those areas. I'm very confident that we'll do the same here. We'll be able to then correlate the view that we have through analytics there with the associated clinical outcomes, as well as, very importantly, correlating these things to the relationship between the patient and family experience. We've started to roll this platform out across the entire UC Davis health system, not just for research purposes, but for quality improvement. This is not real-time management, but this is sort of retrospective management of looking back at the past days and weeks to see how we're doing with the management of our patients so that we can refine our processes. And then what we're just, again, starting to dabble in is this idea of leveraging this cloud-based platform to do mobile health device delivery of the actual products of the analytics to help with clinical decision support. You can actually use this to threshold very sophisticated clinical alerts to providers, so that if I'm halfway across the hospital, so UC Davis is a very large hospital, we have about 1/3 of a mile from one end of the hospital to another, and we have ICUs across many floors, so I can actually have a patient who's crashing on the 7th floor and have to be down in the emergency department. Once I walk away from the patient at the 7th floor, I have no idea what's happening to them anymore. And so the idea here is to basically provide that in my pocket, on my device, custom alerting using the analytic engine and a series of decision support sub-algorithms. So this process has been, over the course of the last 2 years, has involved a lot of people. There's many people to thank, and in the sake of time, I'll focus in on my main co-investigator. So Nick Anderson, who's the director of informatics research for the School of Medicine, and JP Del Planck, who is a professor of mechanical and aerospace engineering and an expert in flow simulation, have been complete partners in crime. JP and I got this project started initially over lunch. And then collaborators, including some from Citrus, who've been instrumental to getting the project going and then also taking it in some new directions. The Adams-Anderson lab, Nick and I run a joint lab. We have a number of very multidisciplinary people in the lab. So we have physicians, respiratory therapists, nurses, computer science undergraduates and graduate students, and then some biostatistician folks as well have been incredibly productive and helpful. Monica, Edward, and Greg have done a tremendous amount of the code writing and have been really brilliant in that regard. And then finally, just to acknowledge and say a heartfelt thank you to Citrus for helping to fund this work and really get it going and sustain its early development. With that, thank you guys very much for your attention.
Jason, thank you very much for a compelling review of how we can really see applied data going forward and creating actionable data, but the complexity of the challenges before us, but also the opportunities. We've run over time. We'll take one quick question for Jason, and he will be available afterwards, but we are sensitive to people have to run to other schedules. So again, Zach, could you start us? Jason can repeat it.
Sure.
Okay, so the way I see it, is most of these ventilation systems are like poorly written self-driving cars. And they go around the track, but there's variation in tracks depending on how you breathe that's going to drive you off the edge.
and you guys are sitting in your little, I guess, pit stop, and you're like, oh, the car's about to veer off its track. Let's go manually fix it. So what's stopping you from going a level deeper, and instead of just being the clinical decision support tool, to actually writing better algorithms to adjust on the patient's respiratory flow?
Yeah, so it's an outstanding question. So the question was, why sit and respond to things coming out of control in a manual way? Why not engineer that same decision logic that we would use into ventilator algorithms that would actually adjust parameters in response to changes in the patient? And I think that's really coming. One of the major challenges is that there's an absence of clinical context when the ventilator is looking only at waveform data. And so I might respond very, very differently to certain changes in one patient who's maybe in the early phases of severe acute respiratory failure than I would in another who's maybe in alcohol withdrawal and about to get extubated and out of control just because they're thrashing around and kind of being unruly. So I think one of the challenges is to develop algorithms that are relatively agnostic to clinical context and can make these fine-tuning adjustments that probably all patients need. I think the ventilator companies have probably been slow in that regard because they don't have access to simulation environments and clinical deployment environments to do this in ways that then result in a safe product. So that's one of the things that we've been starting to work on locally. And then the other is that because of the absence of integration of the additional clinical context, I think that the real fruit comes when you start including additional clinical metadata that help to describe what patient is it that we're talking about, what patient are we about to respond to. And maybe that would be the equivalent of saying, if you had data on the type of road surface and things like that, that would also feed into the car's ability to navigate.
Wonderful. Thank you very much. But again, we're sorry we've run out of time, but we thank all of you for joining us and look forward to you coming to join Citrus again next Wednesday for our ongoing research exchanges. Have a wonderful afternoon.